We are live, Pratik. You can start.
Hello, good evening, and welcome to all the delegates and viewers that have joined us from India and around the globe. Today, we are here again with a webinar brought to you by Cynodent. First of all, I would introduce myself. I am Dr. Pratik Bam, a second-year postgraduate student, Department of Prostho, Tirthankar Mahavir Dental College, Moradabad, Uttar Pradesh. I am Public Relations Head, Team Cynodent. I am co-hosting this session along with Dr. Sritej Jagtap. I'm also thankful to our founder and CEO, Dr. Anmol Bagaria, who is along with us. Cynodent is a unique healthcare platform for the first time in India, a digital healthcare platform that provides and enhances a good relationship between patients and the doctors, and also enables a real-time appointment scheduling system. Our goal to create a easy access to healthcare services and communication ways or appointment scheduling system not only between the dentist and the patients, but also between the medical practitioners, diagnostic lab to the radiological services and pharmaceutical services, and also research and educational programs for the doctors to enhance their knowledge and keep them updated regarding the same. Cynodent bring together at economic prices and minimum waiting time because every one of us have 24 hours and we have to use it without wasting. Cynodent is here to create precious healthy smiles on our patients' faces with minimum effort and maximum welfare. Cynodent is an initiative that will put all of its efforts to create that beautiful smile on our patient faces for now and always. Now patients don't have to fear those long queues and busy dentists when they get a toothache. Cynodent is also working for social welfare and humanity, and also to enhance the quality of life by providing healthcare needs, health awareness, and free treatments. With this, I come to our today's webinar. The topic of our today's webinar is Digital Dentistry, Endless Possibilities. For this webinar, we have with us Dr. Anirudh Nene sir. Dr. Anirudh Nene sir has graduated from Sinhagat Dental College, Pune in 2014. He completed his master's in prosthodontics from King's College London Dental Institute with distinction in clinical cases. He is currently tutor for Clinident prosthodontics program at King's College, UK. He is the youngest key opinion leaders for Dentsply Sirona in chairside CAD-CAM with CEREC. He is currently involved in joint teaching programs aimed at systematic training of dental surgeon for basic implant prosthodontics. He has undergone international training on conometric concept with intraoral welding and CAD-CAM technology by Dr. Marco Degidi, and he's completed his implant training workshops mentored by Dr. Thomas Hanser, Dr. Suvarna Nene, and Dr. Ashok Sethi. He has completed his Phantom Master's course for implant surgery training at IFZI under Dr. Manfred Lang. It is my hearty honor and pleasure to have you on the board, sir. Over to you, Dr. Anirudh, sir.
Hi, Pratik, and thank you, Dr. Anmol and Suresh, for creating this wonderful platform called Cynodent. So it gives the opportunity for the students and your large network to have different kinds of webinars, and this kind of continuing education gives good opportunities for people sitting at home to learn. So hopefully you guys can pick something up from my webinar today. I'm just switching over the screen. Okay. Yeah, you guys can see the screen clearly?
Yeah.
Yes, sir.
All good? Yeah, fine. I'm just going to minimize the, yeah, that's it. Okay. So yeah, my topic is actually digital dentistry, endless possibilities. Well, if I start talking about digital dentistry, I think we'll need about a 5-6 hour webinar. So I'm just going to focus on chairside digital dentistry for today. I'd like to firstly introduce our team. This is my practice in Pune. I'm lucky to be associated with a 35-year-old practice on the right hand side of the screen. You can see it's a team of 4 doctors. On the extreme right is my wife, Dr. Janvi. She's the orthodontist. In the middle is my mom, Dr. Suvarna Nene. She's the implantologist. On the left, Dr. Kozema. So yeah, it's an old photo. You can see all of us together. So this is our small team in Pune, and we have a practice. And I'm going to share with you my experience in digital dentistry and how we started working together. So in terms of digital dentistry, where are we today? I just want to, I'm not going to take a lot of time on this because I have a lot of cases to go through. So I wanted to ask you, what is the choice you have? You often hear dentists talking about digital dentistry and, oh, I've started using digital protocols. I've started incorporating digital protocols in my practice. So as a dentist, you have two choices. You either say, well, intraoral scanners and digital workflows are not feasible at this point, and it's not worth getting it. They're not accurate. It won't fit into my practice. In my opinion, that's an area where you have ignorance is bliss. You have this area where you don't want to think about it. But what we need to face, the harsh reality of today, is that intraoral scanners and digital workflows are already here. People have been using them for decades together. So you would see some of the cases which we've done, some of the workflows which you've used. You yourself have used digital workflows. Anytime you've made any zirconia crown, you've sent this cast to the lab. So the cast has been scanned by the lab technician using an chairside, using a lab side scanner, and he's incorporated that digital workflow in your restoration. So digital workflows have been around, but now the reality is different. Intraoral scanners have changed the game and changed the market. So they're here, and by here I mean India. So do you want to keep denying whether these things are, these things are going to take time, or do you want to accept that intraoral scanners and digital workflows are already here? Okay. So when I say talk about digital dentistry in India, I'm not going to go broadly into all of these aspects. I'm going to focus largely on intraoral scanning and the chairside workflow, which I use in my everyday practice. I'm not going to be talking about CBCTs and how to make guides, and I'm not going to be incorporating all of that because that's beyond the scope of today's webinar and will take a lot of time. So my primary focus is on intraoral scanners, and you will be quite aware that there are several companies that are in the market in India today, and all of them have their top end scanners. This is one from Dentsply Sirona, which is available in the market today. So you have the best of systems available in our country to be utilized, and you can start your digital journey from using an intraoral scanner. And just a small video showing you what the scanner actually does. You also have 3D printers, which are written in my slides. So these 3D printers, what they do is most of the popular labs in the country today have digital printers, 3D printers, and they're using them on a regular basis. They are well versed with the workflows. Back 3-4 years back when we started working with intraoral scanners, a lot of the labs had not caught up with the, not, I won't say not caught up, but basically intraoral scanners were also new to the market. So digital workflows hadn't caught up. But now with the advent of easy to use, cheap 3D printers, this is the reality which we are in today. You can print highly accurate, well-fitting dentures within the space of 30 to 45 minutes, which are aesthetically pleasing, quite durable, and functional. So this is the reality we live in today, and these kind of things are there in the market. So then, given all of this is present in India today, what is the issue with our users not adopting digital technology? So I feel that there are 4 major issues. One of the biggest issues is people are afraid of time and efforts required. That's an intrinsic issue. That is something which we need to catch up on. We need to think about. There are set workflows in everyone's practice. They have a fear of the unknown. So they don't know how it's going to work. They have a set protocol in their practice. Their associates, their chairside assistants, they've been working with different materials for so many years. And now suddenly we've been told that there's something new, something better. So that kind of gives the dentist a fear of changing their protocols. They're set in their ways, and I don't blame any dentist for that, because that's how dentistry works. It's a predictable science, and we take efforts to make that science predictable. And once we make that protocol predictable, and suddenly somebody comes along and says there's a better way of doing it, it takes time to transition into that space. Okay. One of the last thing which people have an issue with is the learning curve. People feel that the learning curve is quite steep, and again, it combines with the fear of effort, of time required. So a combination of the two most likely leads to people not entering into the digital market. So I'm going to ask everybody here that think about it. Do we need an intraoral scanner? Are you using your digital protocols and digital practices? Do we actually need one, or are you fine with your regular PVS impressions? Well, I have 3 points to ask you today. That I have 3 issues with using PVS impressions. First is the precision, second is the patient experience, and third is the time. When I talk about precision and predictability, I'm not going to argue whether digital impressions are better than well-taken PVS impressions. I feel both of them are as accurate as each other. But the biggest issue I have is there is a lack of repeatability. I will not be able to reproduce the same kind of impression again and again and again. And that's not because I'm a bad dentist, it's because that procedure is technique sensitive. There's high interoperative variability as well. You have 4 colleagues who are working with you, and all of them take the same impression. It's not going to come out the same. And the reason for that is the biggest reason for that is the analog workflow is bound by all of this. Digital impressions are not bound by all of this. If you can make mistakes in a scan, you can go back, edit them, and they'll still be as accurate as your analog impressions. Okay. Second is the patient experience. In India, especially, we are facing an influx of hundreds of thousands of dentists graduating every year. You have 5, 6 different dentists practicing very close to each other, and the competition is intense. Patients don't anymore come to you just wanting to get their problem solved. They come to you expecting a good experience. They want to come to a dentist, feel comfortable, and go away. They don't want to have an experience where they are almost made to feel so uncomfortable that they hate coming to the dentist. I mean, honestly, we are a market where patients anyway don't like coming to a dentist. So what can we do as dentists? We can do something to make their lives much better. So patient experience, definitely there is a huge leap in terms of patient experience with chairside scanners, intraoral scanners, as compared to analog impressions. Of course, when you look at time, there's a nice study out there. You can go through it. Time in terms of the chairside time which you use, that is also greatly reduced using digital impressions. The number of visits are also reduced. You'll see how the number of visits are reduced with the workflows I use. And of course, the patient experience, which I stressed on. How many of you have had this in your clinic where you've put your alginate impressions or God forbid your polyether impressions in the patient's mouth and patient starts to gag, and it becomes something which the patient has got to carry in his mind. So I'm going to jump into the chairside workflow. CEREC is now 35 years old. It's a chairside CAD/CAM system introduced way before I was born. 1996 was the CEREC one, which was commercially available, and that was when they were saving patient data on floppy disks. You can see that the top left of your screen, they had these single burrs, and they were milling inlays of the patient. And from there, we've come a long way. At the bottom right, you can see that this is an optimized system where on the right is the chairside scanner, in the middle is the milling unit, and on the left is the sintering furnace. These 3 combined have totally revolutionized digital dentistry and chairside dentistry. The idea is that dentists are now empowered to make restorations themselves. This is the unit, our setup I have. It's one of the older generations of the same system, but it works equally effectively, and I have been using this workflow for more than 4 years now. And let me tell you, it has completely changed my practice and completely revolutionized the way I work. Okay, this is the latest 4-axis milling unit which they launched. It is the fastest milling machine in the world, and I was lucky enough to see it live in January before COVID hit, and it absolutely blasts through a zirconia crown, and it will mill a zirconia crown in 4.5 minutes, which is absolutely crazy. I just wanted to show you a quick video of that. So they've managed to come up. It's a feat of engineering where two burrs are simultaneously milling it from all sides and two burrs are simultaneously finishing it. It takes a huge amount of research and mathematics to come up with this, and they've managed to figure it out. So I'm not going to keep harping on how the machines are good. I'm just going to tell you what the advantages of doing in-house milling is. So one of the first advantages, you're going to be saving lab costs on the final restoration. India is a very price conscious market. There are different pockets, there are different demographics of patients you're going to attend to. So according to that, the savings on the lab costs which you are going to get are going to be substantial when you start using in-house milling. The best thing, or my favorite part about in-house milling, is that the flexibility of the material of choice. So as a prosthodontist, I often face this dilemma that I am not able to work with the material I think will work best in this case. When I got the in-house milling unit, I went absolutely berserk. I started ordering all kinds of different ceramics, there are about 48 different restorative options with this machine. I've just highlighted some of the ones which I always use. You can go right. You can start with from polychromatic multi-translucent zirconias to your workhorses like Emax, and then you can move over to some of the new hybrid ceramics, or you can straight away jump into indirect composites, which you can mill chairside. This gives me the flexibility of choosing the restorative material of choice where indicated. I don't have to think about if my lab has that material option with them, will they provide it at a reasonable cost? All of these material choices are available in roughly the same price ranges. So you get to decide what's best for the patient without having any other things affect your decision making. Okay. So I'm just going to show you what the protocols and what workflows I incorporate. So using the system, you have the flexibility of including or involving your lab as well. So you can have a seamless workflow where you export either the case to your validated labs, or you directly just start milling the restorations yourself. So you can either export the scan to your lab. If you don't want to mill it, you still have the option of just doing that. You have the beautiful option of educating the patients. We have incorporated a system in our practice where every single patient who has major restorative work who comes to us gets scanned. And the simple thing is that when you scan the patient, it's very easy to talk to them about what's wrong in their mouth and how we can fix it. So the visualization of the problem really helps the patient understand that they need or they require treatment. You can also upgrade to the chairside workflows, which I've done. You can send it. It's now validated with ExoCAD. So most of our labs in India work with ExoCAD. So you'll be able to export colored scans, which is very important. You don't lose the texture and color while you're exporting it. You can, I'm just going to skip forward to this. You can seamlessly work, have multiple partners working for you. So that's how everything works. So I'm just going to show you two quick workflows. I'm not an orthodontist, so I'll show you my restorative and implant workflows, which we incorporate in our practice daily. Primarily, I'm going to be showing you my restorative workflows. So this is what we do. Basically, we start with the scan. We design the final restoration in the software. I mill it in my milling unit. My patient is sitting in the operatory, and then while the restoration gets manufactured, so we have managed to merge these into one workflow where if I have a single unit lithium disilicate case or a single unit Emax case, the patient will start the procedure and finish it in about 2 hours. And this is with me going through all of these steps. I personally design, mill, and stain glaze my restorations. You can, of course, outsource this to your lab technique, to your chairside assistants or your associate doctors, and you'll further narrow down the time. I know a few CEREC doctors who are using this workflow manage to push through with these inlays and onlays with 1 hour. Okay. So these are some of the additional features in the software. One of them is shade taking, which is quite accurate. You can use it as a reference for your anterior cases. The second thing is it gives you a preparation analysis. So one of the best parts about this is it will absolutely ruthlessly massacre your preparations if they are not done properly. So the machine doesn't lie. So you can't get away with that. So it's improved. It's managed to improve my preparation substantially ever since I got it into the practice. You also have flexibility to play around with the material thickness, the intensity of the contacts, the dynamic occlusion. So that gives the flexibility of customizing the restorations really, really nicely. So those of you who are facing any issues of fit, any issues of high points, you can really, really, really customize it on a micro level and manage it quite well. Okay, so I'm going to dive right into the deep end and show you a quick case. So this is one of those typical cases on a CEREC day where we have a patient who has a deep distal occlusal cavity and has gone for a root canal. So we do the endo. I'll do a minimal invasive onlay preparation with some immediate dentine sealing, and the patient is scanned in the chair. She sits outside and we bond the final restoration, and she's gone home within 1.5 hours. Patients really like that. They prefer to do everything in 1 or maximum 2 visits. I'm not saying you can push treatment, which is indicated for multiple visits to a single visit, but I'm saying that things which need that lab time can be constrained, and you can finish all the work in 1 day. And you can see on the X-ray that the fit of these restoration is seamless. If you get your preps right and if you scan properly, it's just like your previous impressions. If you do a good job, you'll be able to deliver good work. So just another case of an Emax onlay. This patient came to me. I don't have the pre-op with me, but he had a distal lingual cusp fracture with extreme sensitivity on that tooth. He said, "Doc, I'm flying off day after. So do something for me today. I can't wait." So for patients like these, you're normally restricted to either doing some temporary restoration or doing composite restoration and asking the patient to come back. This case, I knew there was a crack. We traced the crack. I've sealed it with some immediate dentine sealing, and we've quickly milled a nice Emax onlay on top, and we have bonded it, which merges very well. So this kind of flexibility gives me the option of actually recommending treatment protocols which are ideal. Because of the time constraint, we often deviate on recommended protocols, but this has enabled me to give access to these kinds of restorations. Or a simple case of a posterior tooth after an endodontic restoration. Emax also merges beautifully. We have multiple translucencies to work with. So this is a high translucency block which I use. It reflects the color of the internal tooth surface. That's why it merges quite beautifully. So you can see on the buccal photograph, it's blended in superbly. You can't see the margin anywhere, and that's what patients appreciate. When I showed this photograph to the patient, and I said, "Please identify where your restoration is." Unfortunately, confused it with the lower crown, but I said, "No, I was working on your upper jaw." So yeah, that's what patient really appreciates. They don't need to come back again. It stays with you. It stays with the patient. You have the patient going back home and then talking to his relatives and saying, "Yeah, I had a root canal done, and the crown was done in 1 visit only. I can't believe it." We have often patients coming back to our milling units and seeing how the milling works. It's pretty cool. Yeah, you can do all sorts of restorations. I've tried to mix and match some cases to show you different restorative options. We have a patient who had kept fracturing his disto-occlusal class 2. So I quickly removed all the previous filling, did an inlay preparation, and composite is even faster. It takes about 8 to 9 minutes to mill and about another 5 minutes to stain glaze. And using that, I just quickly bonded in that inlay. So this kind of workflow gives, again, stressing on the material flexibility. This is just a fun case I've added. There's a little kid who fell on his front tooth and he chipped it off. So just to cheer him up, I told him, "Well, you can make your own restoration." So he was quite interested in the workflow. Normally, 99% of the times I would do this with a direct composite, but just for fun, I thought, well, let's try something. So this is actually we designed the filling together. He found it pretty cool. He's a very small kid, so he was quite happy to do it. Quite amazed and impressed to see this. And yes, you can see that the restoration has blended in quite well. Or you have difficult anterior cases. This is one of the most challenging restorations out there for any aesthetic dentist or any prosthodontist to match a single central incisor which is discolored. This is one of the most difficult things to do, but we managed to do it using a different kind of block. What I've done is I've just added a composite opaquer on the tooth to mask the discoloration. And I've used a polychromatic multi-translucency block from Beta, which is Dynamic. It's a hybrid ceramic composite mix. This is milled out in about 10-12 minutes, and we have used some light composite stains. The best part about using this is I've just put the crown in the patient's mouth without bonding it. I've stained it in the patient's mouth to match the adjacent central. Then we've gone back, finished off those stains, and then bonded into place. You can see that the restoration merges quite well with his natural tooth. So yeah, you can take on some difficult cases with CEREC as well, and you will get decent results. This is one of my own cases. This case was treated in our practice about 10, 12 years back, and she had some Emax restorations done by another associate, and she came back to us again after 10 years and said, "Oh, my crowns are fractured." So at this point, the patient was pretty angry that, it's only lasted about 8-10 years. It's fractured. They told me it's going to last a lifetime. I said, "Wait, hold on, calm down. I'll be able to give you these crowns in one visit." Now, this is one of the perks of having CEREC. You can pacify patients like these who she had restorative work done in our practice. So for her, she wanted a restoration straight away. So we quickly removed those crowns, scanned it, and I quickly bonded the same crowns into place. Yeah, these are the new crowns which we milled in CEREC, and this is a low translucency block I've used. So the versatility of the system is you can incorporate different translucencies, different blocks to mix and match what ideally works for you. Okay, or this lady, for example, she had two full ceramic restorations done in Canada. She used to get bleaching done every single year. Now she came to me and she said, "I'm tired of bleaching. Can you please merge these crowns with my existing restorations?" This is one of the cases I wanted to show you because she told me one thing. She said, "I'm very happy with the shape of it. I don't want you to change the shape whatsoever." Now, when you're doing this kind of case, there's always a doubt in our minds that can we replicate the exact same shape? But using the software, we can copy the existing condition, existing scan. Will take up a reference of what the shape is in the patient's mouth, and you can design the final restoration according to the existing shape. That allows me to basically copy the shape the patient wants. As you can see, I've designed it absolutely accordingly to what the patient previously had. And using some simple staining glazing, we merged these two Emax crowns with her adjacent teeth. Now she's happy. She said, "I don't need to bleach my teeth anymore. I'm quite happy with this shade match." So we started here, and that's how she turned up with. So you can use CEREC even for smile designing. I'll be showing you some incorporation of different kinds of softwares to work with this. This is a beautiful image taken by one of the talented technicians I work with, Mr. Mohit Suryavanshi. So we managed to work together on some cases. This is the story of a guy who had 4 anterior PFM restorations done long time back. And he had some periapical abscesses with them. So he went to a dentist. He got the crowns removed and he got these temporaries made. And he was absolutely unhappy with the work done. So he came to us with his old CBCTs, showing us infection in all the canals. Dr. Kazama managed to stabilize his endodontic condition. And after Dr. Kazama finished his root canals, we managed to stabilize him with temporaries. I've put photos of 2 different kinds of temporaries on the right-hand side, just to show you that we can mix and match. I milled out 2 sets of temporaries just to show you how I can look at different shapes and how they will look like in the patient's mouth. Finally, we settled on one particular shape which the patient liked and the patient was happy with. I copied that exact shape in the software in the scan. Yeah. Once the period of temporization was over, the soft tissue had healed beautifully. I already had the reference scan of what he wanted and what was going to look good on his face. So once I had that, we took a scan of his preparations. I designed these Emacs restorations in the software, and we milled them chairside. I took a little bit help from Mohit on this case, where I sent the final restorations to him for a little bit of texturing and staining glazing. But he managed to help me out on this one, and with it, we could successfully give him beautiful looking ceramics. Yeah, so you can see 4 bonded restorations, and we've given the soft tissue enough time to recover. And now these restorations are exactly how we had imagined them, how we had envisioned them. And when the patient smiles, he's pleased with the aesthetic result. So this is where we started with. This is how it works. On the right-hand side, you can see that her design and her final restorations have managed to be the same. I mean, the scan is enlarged, obviously, but you can see that the shape has been maintained. So the software is quite accurate. Is what you see is what you're going to get when you mill the final restorations. This is one of those cases which was quite challenging for me. This was an ortho-restorative case. So I worked closely with Dr. Janvi, and she managed to stabilize his pre-op condition and do a very good orthodontic treatment to stabilize him. I don't have the post-ortho pictures, but this is what he came back with after the ortho was done. There was good contact. I was quite happy with it. Now, just a bit of background, his central incisors and upper right lateral incisor was root canal. So these 3 teeth were already root canal before we started. This is how we came with. And using digital technology, we were able to communicate to him exactly what he was going to look like in the final result. So after the orthodontics was over, I did an intraoral scan. I sent the scan along with a facial photograph to the lab. This is especially useful not just for patient communication. You can see that we have designed it with minimally invasive preps. So I'm not going to be touching his canines. His canines are quite good. They just need to be slightly bleached. Rest of the shapes are quite nice. So we've managed to manage this conservatively. You know, those 3 root canal treated teeth have been prepped, and the left lateral has been very minimally invasively prepped for a veneer. So this is what this is a good idea for you to visualize. Unfortunately, ExoCAD doesn't give you a lifelike simulation of the smile. So if you show this to the patient, he'll run away. But for that, I recommend you use the DSD software. The DSD software, which is available even on your iPads or your phones. What they can do is they merge the final result very, very nicely. And for patient conversion or patient projections, you can use those. But for your planning, ExoCAD is a nice tool, is a nice software which most of our labs are using. So this is also done by Mohit. So this is how we came with. He was shy, not willing to smile, afraid of his smile. We planned the final result, and this is how he went home with. So you can see he's managed to smile more than he was before, because he's absolutely elated with the final result. This is some errors in the slide. Oh, just a second. Just go back. I'll just quickly change the animation of the slide so that there's a lot of overlap here. Yeah. Okay, I think we're good to go. Okay, so we tried something which we haven't done before in this case. Oops, just delete this. There's some error. I'm unable to show you the full protocol, but basically, yeah. Basically, this is how the patient came to us. She had existing crowns done about 10 to 12 years back. She had 2 I believe it was Empress, which was done on her central and lateral incisor, both root canal filled, and she had a badly stained composite restoration. Now she wanted her smile in a particular way. She was very, very finicky about the final result. So I managed to cut off these crowns, and we just did 3 restorations, not more than that. But these have been done with the help of an intraoral scan. I have exported the scan to my lab, and we were trying to work with a new workflow. I won't be able to show you her 3D facial scan, which we had taken because she refused to share that in my lecture. But I will show you what is possible currently with softwares which are pretty much free. So this is how we got the final result. It's very easy to visualize using 3D facial scans. You can actually integrate. This is a scan I took of myself to show you how we can work with that. So Bellis 3D is a wonderful app. You can just download it on your phones and take a facial scan. It works with certain phones. I think it works with all phones which were made after the iPhone X. So you can just straight away take a facial scan. You don't need to buy a 50,000 facial scanner. And now this is a facial scan of me at rest. You can take a facial scan with the patient smiling fully. You can then export this file to your labs, and then the labs can merge your intraoral scan and the facial scan to give you a final result which looks good in 3D. So we use that for the previous case which you saw. Unfortunately, I won't be able to share with you her 3D facial scan, but it was quite an interesting workflow option which is available currently today. So quickly to jump on to the implant workflows, one of the things which has really changed my practice is implant workflows, particularly with implant restorations. Now, CEREC guided workflows is something which all you practitioners, all you young implantologists, all of us can really incorporate in our practice. Senior implantologists who've been doing freehand surgery for decades together really don't find it hard to do single implant cases. But for us, when we are entering into the field of implantology, when we want to get the implant position critical, it is imperative that we work with some kind of reference. So this software allows us to both merge the CBCT scan and the intraoral scan. And it actually has an inbuilt workflow where you have to plan the restoration before you plan the implant placement. So you plan with the end in mind. So the workflow forces you to do that, which is what I like. So basically, you have the sleeve-on drill system. I'm not going to go stress on guys much. Or you have the drill key system. These are the 2 systems available with them. They are universally available for most of the implant system. Sleeve-on drill system is only available for Dentsply Sirona's proprietary system. But basically, to give you an idea, we plan the implant restoration first. Then we import the plan file into the CBCT software, merge the 2, then plan the implant placement. And then once both of these things are planned, we export the plan to make a nice surgical guide so you can get your implant position bang on. So this is how it works. With once the guide is attached in place, basically the entire surgical kit which you get with your implant system is different. There's a surgically guided kit which will help you use any kind of drill system available, and without having any kind of change in the guide. You can see that they have a beautiful master sleeve system where the sleeve locks into place. There's no wobbling of your handpiece inside the guide. It's internally irrigated. You can see that the channel and the switch locks into place, and then the drill passes through seamlessly. So yeah, I'm not going to stress on this much. We can just move forward. So implant restorations are something I want to show you how we have managed to incorporate in our practice. So this is what I call back in 2017, before CEREC, what we used to have. So most of our patients had surgical placement done by my mother. She's experienced in her practice. So the surgical part didn't last too long. It was relatively painless. But when they come back for the prosthetics, they start complaining because they say, 100 times you're removing the formers, you're placing the impression post, verification, it hurts. And you can agree, this is the same workflow which is used mostly. You're going to access the implant, you're going to take impressions, you're going to verify, you're going to do a trial, and then you're going to do a final. So by the end of it, implant patients are saying, finally I got a tooth, but I don't want to do an implant anymore because I had to come so many times. I was in pain. I was the surgical part was seamless, but the prosthetic phase is something which is causing a lot of discomfort. So now I should change this to 2020, but now in after the digital era, this is what we do. We access the implant, we scan it, the patients sit in our operatory, and we finish the final restoration. We go a step further. In some cases, we place the customized healing abutment at the time of surgery. And when the patient comes back, we have the beautiful gingival profile ready. So we don't even need to spend time on customizing the gingival profile. It's already done. And we just scan and give the final restoration. For that, the patients really appreciate the workflow. Now, primarily the workflow works on this abutment called as the tie-base abutment. Now, what is the tie-base abutment? This is an abutment which is universally available with all implant systems in the world. This abutment is a very short cylindrical abutment with no anatomical form of its own. It allows you to fabricate a superstructure on top of that. Now, the superstructure can be in the shape of an abutment, or it can be in the shape of a final crown. So you have the flexibility of doing that. Now, the best part about this is it just opened up an entire world for me. I was not exposed to tie-base abutments apart from their use in all-on-4 and all-on-6. But this just changed the way how we are doing single implant restorations. So the precision of fit of these restorations is immaculate. You can see there are blocks available with Dentsply Sirona or Ivoclar. They come with the screw access hole, which is pre-milled into the block. That way, you can be rest assured that the titanium base is going to fit to the block quite passively and quite beautifully. This is a magnified photograph to show you the fit. This is Emax, which is pre-crystallized. I just wanted to show you a picture of how well it seats, and the pre-crystallized blue Emax was giving me a nice contrast. So this is an enlarged image of that. So jumping right into the workflow, you can see single implant restoration. We've not customized the soft tissue profile much. We've just simply put a regular former, and then patients come back, quickly scanned and given her an Emax crown. Okay. One of the biggest problems now we are facing is making beautiful soft tissue profiles, and when you transfer those soft tissue profiles onto your models, they don't get replicated as accurately. When your lab technicians send you a final result, it's fitting well on the model, but when you place it in the patient's mouth, the soft tissue profile is captured, but it's not captured exactly. So using digital technology, the soft tissue profiles which you've created, you've spent months on getting that beautiful zenith, beautiful symmetry of the papillas. This is what you want to capture. Now, this is something which you can capture beautifully in the software. The software allows us to just remove the gingival former at the last minute and scan immediately only that area. You can see that there's a difference in the color of the scan between the adjacent teeth and the scan of the titanium base. Now, the reason for this is what I've done is I've pre-op scanned the patient, and when I'm happy with the soft tissue profile, I've just in time removed the customized gingival former. In this case, it was a customized temporary, and managed to capture the exact soft tissue profile. So, especially this is very important when you have adjacent implants. Everybody knows how hard it is to capture the soft tissue profile over there, but using this, you can capture the soft tissue profile quite well. And now the patient wants to change his right side. I'm just going to show you different cases using different materials. Again, you have flexibility of using 3-4 different materials with these workflows. This is a case where we have used zirconia in this case on a small titanium based abutment, but it works. Some of you may have a concern that the height of the cylinder or the height of the abutment is not enough, and there can be cantilevering which happens. Will that dislodge the restoration? Will that debond the restoration? But using these workflows, believe me, I have not had a single titanium based implant crown debond, or I have not had a single tie base implant crown not fit. The workflow is seamless and it gives a fantastic result. Once again, the software allows you to customize the exact amount of pressure you want to exert on the gums, the depth at which you want to place your margins. We all know that when you place your cement retain restorations deep into the sulcus, there is a big issue of cement sepsis causing peri-implantitis. But using the software, you can take the gingival placement depth and make it equigingival, or if you're using the same restorative material, you can even keep it supragingival. So I mean, that kind of flexibility is what I enjoy using. The software customization is fantastic. For those of you who are not aware of the workflow, there's a short video I have. Uh, this is how we work with. So this is a scan post which is used, and there is a scan body which comes on top. Now the scan body which is used is the one which is giving the exact position of the implant in the patient's mouth. So once that scan body is placed in the patient's mouth, and that is registered in the software automatically knows at what depth and what angle the implant is placed. After that is done, the soft tissue profile is also scanned, and then the opposing jaw and then the buccal bite are scanned as per your regular intraoral scanning. And that is how the software identifies where the implant is placed. Now, these kind of scan bodies are different for different softwares. They're different for different implant systems. With CEREC, there is a universal scan body or a scan cap, which can be identified. That's the gray thing on the top. It can fit directly into a titanium base or an extended titanium base if you need one. So that's how we work with. This is the titanium base. This is for Dentsply Sirona's ankylosing system. You can see that there's an anti-rotation notch on the tie base. So that anti-rotation notch matches with the anti-rotation notch inside the milled crown. So that notch is also prefabricated. So everything is prefabricated. The orientation of that notch determines how that crown is oriented in the patient's mouth. So this is a model-free workflow. I have no model to seat the tie base in the exact position and seat it on. It's this anti-rotation notch which is giving me a reference of where the crown is going to be located in the patient's mouth. And here is a quick video of us doing a live case. Blur the music. Yeah. So this is, we are scanning the patient that's slightly fast forwarded so that we can quickly go through this. Yeah, I've removed the healing abutment and I'm scanning the soft tissue profile. We're now scanning the scan body, which you saw in the previous photographs. It's quickly captured. Once it's captured, immediately the software gives me a tick mark. This is the buccal bite. I just have to ask the patient to close and take the buccal bite, and the bite is recorded. This is one of the best things of the software. I can customize the soft tissue shape as per my requirements, how much amount of pressure I want to give the soft tissue. I can check the articulation with the articulation features. I can check static and dynamic contacts in function. So, I mean, what more do you need from your implant crowns? Yeah, so this is how it fit. Right on the same day, we removed the gingival former. So you can see it's blended in quite well. It's the upper right 6 for those who needed the reference. Yeah. Or a case like this where you have customized the soft tissue profile by giving a chest-side temporary, and now you want to capture this profile, we can capture it in the software. This is milled in, again, I believe this was an Emax restoration, which we did. Or you can do challenging cases which require complex staining glazing or complex lab side protocols, but you can use the chairside software. I'm going to quickly play a video for you to show you the features of this. Oh, sorry. Yeah. Yeah. So here you can see I'm just changing the soft tissue profile, and this is the first design that the software gives me. Now, most of the times the design is okay, but sometimes I need to modify it slightly. You can see I'm just quickly working on some of these areas which I'm not happy with, which the software has given. Again, there's full flexibility. I can modify, change it 10, 15 times, how many ever times I want. I can mill it in a temporary block and check it, ask the patient to wear it for a while, and then come back, modify it further if needed. Yeah, I'm just going to quickly fast forward the video to show you one of the best things I like about the software. Now, you can see obviously the implant crown is on the canine. I don't want a lot of heavy occlusion on the canine, so I'm going to have shared guidance in this particular case. So using the articulation tool, I'm just going to quickly verify I can also not just check the lateral guidance, I can check how quickly the lateral guidance is being transferred from one tooth to another. That's one of the best parts of the software, and I can quickly customize the shape and profile of the final restoration as per my needs. So here you can see we have blended it with her. These teeth were difficult to mimic, but we managed to get a decent result out of this case. So quickly, to show you the versatility of what I can do with the system, I'm going to quickly show you 3 anterior cases where I've done 3 different things. Why am I showing you this? This is because I want to show you the flexibility of the software. I want to show you the flexibility of the workflow. You can decide what's best for you. I'm going to skip forward through the surgery because we don't have time now. So I'm going to quickly introduce you to what this case was all about. So we're just going to move ahead. Yeah. So this patient walked into our practice with what I believe was splintered restorations. He walked into our practice with his CBCT records, his blood tests. He was ready to get operated. He said, I've come from Jammu. I want to get these restorations done. I want to get my implant placement done. Basically, his upper right central incisor had fractured, and he managed to get it bonded to his adjacent central. Unfortunately, this adjacent central was a vital tooth, which was prepared, but they have sealed this entire thing with composite resin. We had no reference. We had no time to make a temporary. We just knew we were ready to go. So what did we do? We removed the composite very minimally. You can see that the left central is quite invasively prepared. The right central had just broken off completely. We did a quick socket shield on that tooth, placed the implant, and I have milled 2 different kinds of materials here using the CEREC system. I have on the left side, I have milled a temporary veneer using a PMMA block. And on the right side, I have milled an implant crown using a hybrid ceramic block. So why have I done that? You'll see on the scan, you can see that we were limited by the palatal bone plate. So although we tried to angulate the implant the best we could, we still had a buccal screw access position. Now that's going to hamper me to give him a direct screw retained crown. So instead of that, what I've done is I milled the block in hybrid ceramic, which will allow me to give him a veneer on top of that to get the final results. Then he went back to Jammu. He came back after 6 months, and this is how he was looking. The soft tissue profile was okay. We were happy with it, so we went ahead. Now what I've done is I have prepped both of these. Now because it's a hybrid ceramic, it's very easy to prepare in the mouth. So I've done a veneer preparation on this hybrid ceramic. This is an enamic crown which I had done, and I have done a regular veneer preparation on his adjacent tooth. So doing that, we have scanned the same, and now he's ready to get his final veneers bonded. You can see on the right that the implant screw access hole can be clearly seen, and on the left, it's a minimally invasive veneer preparation which I have done. And this is the final result. So in such a case, when we were constricted for time, when we had no reference of planning, we couldn't even send these models on for a wax up. In normal scenarios, we would have been totally lost. We would have to come up with some out of the box ideas to give him temporaries. But luckily, using these chairside digital workflows, we managed to take him from there to here. And he's quite thrilled with the final result. Our case 2, a simple case, what looks like a simple case in surgery. We didn't have enough primary stability to give him a direct final restoration. So I milled him a temporary crown, and this is still milled in hybrid ceramic. So we have managed to, again, this photograph is to show you the buccal soft tissue profile which we've created. Again, I'm running short of time, so I'm going to quickly move forward with showing you these slides. So now this is at the time of surgery. You can see the sutures are in place. Now I've kept this as it is. The patient is happy with it. He says that whenever he will opt for a complete smile design because he has some wear on his anteriors, then he will choose to change it. But this is the flexibility of the system. He doesn't need to change it. He's had his surgery, and whenever he goes for a full smile transformation, we will change it. Or case 3, for example, fracture central incisor. This kid was flying off to Amsterdam in a week's time. We didn't have time. Luckily, there was an anterior open bite and we have enough primary stability. So I immediately loaded it with a direct final Emax restoration. And he came back after 9 months, and we see that there's beautiful stippling. The soft tissue profile is not collapsed, and patient doesn't need to change the restoration. Or we have done some immediate loading cases in occlusion with good results. Say that there was a fractured premolar, placed an immediate implant, given this lady Emax crown on that. This is right after surgery. You can still see that there's bleeding there. And this is about 6-8 months after she came back. You can also mill an abutment and mill a suprastructure on if you have cases where there's excessive vertical or horizontal cantilevering. You can mill your abutments and mill a direct final restoration on top. So the system and the software allows you to do that as well. You can do quadrant restorations. You can do multiple restoration. These usually are not done in one visit, but they're done in one day. So I tend to schedule them in the morning while they go back, take a break. I mill and design the restorations, and the patients come back in the evening and have the final work done. Quadrant dentistry has really been enhanced with CEREC. Now this patient flew down for some quadrant work. He had 2 amalgams which had some cracks on them. We had implants which we had placed 3 months back, so he came back. Now in this time, what I did was I started milling his implant crowns, and while his implant crowns were being manufactured, we started doing his onlays. So removed all the amalgams, prepped him for some minimally invasive Emax onlays, and we finished this quadrant case. This was, I believe, we started at 10 o'clock and we finished by 2:30. So the whole morning session was expended, but then he could go back with everything done in one day. This kind of case would have not been restored in one visit. I would have had to give him the option that you come 3-4 times, or then you only do your implants or only do your amalgams, or couldn't have done both. You can also export the STL scans to the lab. You can 3D print your models, and your labs can fabricate. For those who don't want to mill their restoration, it's not a compulsion. You can send it out to the lab, and the lab will 3D print a model and give you a final ceramic crown. One case which I'd done similar to that was there was an anterior failing 6-unit case. So this was immediately loaded with some PMMA temporaries. And after the soft tissue profile had healed, I scanned the same and we had exported it to the lab. The lab work is done by Mr. Hayati from Bangalore. So he's done some beautiful monolithic zirconia with some no layering. This is only staining glazing, some gingival layering to mimic the soft tissue profile. You can also use CEREC for full arch implant cases. It's quite challenging to use it, but you can. This is a 3D printed temporary which Mohit had given us after the implants were ready. Now we had to fine tune the 3D printed temporary to her smile profile. After we fine tuned it, I want to copy the exact same thing for the final. So in that case, I will scan the temporaries and send it out to the lab. And then the lab will absolutely make sure that I get the perfect kind of result in the final restoration. So I want to conclude with saying one thing, that with CEREC, the possibilities are endless. With digital dentistry, you open the door to your mind, you open the door to your practice to completely change and transform the way you do things. I'm going to finish this presentation with a offbeat case to show you. This is a patient. She's a gynecologist. She had a failing dentition. You'll be surprised that this dentition is the same except for the upper left central incisor for the past 8 years. She has undergone multiple flap surgeries. She undergoes routine scalings every 3 months for the past 5 years. And she said, somebody told me my teeth would fail in 3 years, and it's been 10 years and my teeth are here. I've only lost one tooth. Now she has no teeth at the back. So we of course discussed the possibility. In my mind, this still is a full arch implant case, but she wanted to keep her teeth for as long as possible. And as patients often have emotional attachment to their teeth, and why shouldn't they? So we did a contingency planning where we have grafted her posterior area. We placed implants. This is the tooth she wanted. She said she had to attend a very close friend's marriage, so she wanted her smile for that marriage. And this was unfortunately before COVID, so she couldn't escape with wearing a mask. So she wanted a final restoration. He said, "I'm not going to wear dentures." So I said, "Fine." So we have placed the implant with the assurance that someday her teeth are going to fail. We'll include these implants in a full arch rehabilitation. But till they fail, we could give her a crown in CEREC. We could mill the abutment, customize it like her root form, and we have made a final result. I milled this in composite to match her teeth, and she could smile at her best friend's wedding with whatever I gave. So this is a slightly offbeat case to show you that with CEREC, the possibilities are endless. All you need is an open mind. Thanks.
Thank you so much, Dr. Anandan. It was a wonderful presentation with all your cases and with different kind of materials which you described it. And it's really that like the more you talk about ceramics, which is very less. So thank you for giving your time. And so like in your presentation itself, you answered most of the questions. Just wanted to ask one question that which smile designing software one should prefer?
Okay, so smile designing softwares, I use a combination of all of them. I use DSD to show my patients how the final result is going to be like. But with smile design softwares, if you use DSD or if you're using, there's one available from the AACD as well. There's a risk that you give the patient something which you're not going to be able to deliver. So you tend to overpromise, overshow them, and then under-deliver, because DSD will give you ideal smile design projections. So DSD is good to show the patients what they want, and you can use ExoCAD or you can use the CEREC smile design software to make your final restoration. You can even use the DSD workflow, but in India the pricing is slightly high for the patient, so it's not practical. So you can use DSD to give the smile simulation, and you use ExoCAD with your lab to give you the final result. So I think that combination works well for me.
Okay, great. Thank you so much, sir, for answering the question and for your great presentation. I would now like to call upon Dr. Anmol.
Thank you so much for giving us your valuable time this evening. It was really informative lecture. I hope this would help the practitioners to more and more enhancing their skills. Thank you so much for being with us today.
Thanks to Cynodent for the opportunity.
Thank you.
Thank you, sir.
Yeah.
Ending the session.
Yeah.